Hi, my name is Dr. Richard Hilton. I'm a general surgeon and a trauma surgeon, and you're watching Knife Skills. So last week, I posted a reaction video to one of Dr. Glaucomflecken's videos about general surgery and had a great reaction from it. I think Dr. Glaucomflecken is an incredibly talented comedic physician. I'm not even sure what to call him. He's on TikTok and he has a YouTube channel with about 300,000 subscribers. So I really enjoy his videos, and I thought I'd do some more reaction videos related to some of his general surgery content. So I found a few that I think might be interesting. So let's get started. So this is a classic situation when you're in the operating room. So cutting a stitch in the operating room might seem like a simple task, and certainly is. But it's a good opportunity for us as surgeons to actually give medical students an opportunity to do something in the operating room that's relatively low stakes. If, for example, we actually cut the knot or undo the stitch as a result of that process, having a medical student cut that, it's not the end of the world. We can redo the knot, redo the suture if we have to. And so that's okay. And giving them the chance to do something will give them confidence to go and do the other skills. When you're training someone, you start at the lowest level of skills, the simplest low-risk skills, and you build on that. And cutting the knot, believe it or not, or cutting the stitch, not on the knot, is an example of one of those skills. Now, even as a staff, sometimes you cut the knot or you cut the stitch too short. There's an old expression in surgery. There's only two ways to cut a stitch, either too long or too short. The other day I was in the operating room assisting a neurosurgeon. He was putting in a VP shunt. The patient had a complicated abdomen. And so for a ventricular peritoneal shunt, sometimes a neurosurgeon will want general surgeon like myself to help him with the abdominal component. So to do that, I put in a laparoscope to inspect the abdominal cavity to assist him placing the shunt. That went fine. But at the end of the case, he was assisting me closing my part of the incision. So I closed the incision and then he cut my stitch. Now in neurosurgery, I suspect they cut the knots quite short, but in general surgery, oftentimes we leave our tails relatively long, and he cut the tail too short, and I was like taken back. Now I had prepared for that possibility and had enough knots on my tie so that cutting it too short wasn't going to be a major problem. But I found myself like sort of shocked, like, oh my, that knot was cut way too short. And if I had been dealing with a resident or a medical student or someone who wasn't at his level, I would have definitely provided feedback. But here I was dealing with a senior general surgeon, or excuse me, a senior neurosurgeon. And so I said to myself, okay, you know what? I'm just going to not say anything. It's fine. The patient's fine. But I definitely held back. So I can understand that feeling of cutting the wrong part of the knot or cutting it too short. This one's general surgeons go to therapy.
Surgery, do you know why you're here today? Yeah, I was told to come here to receive my world's greatest surgeon award, but instead I'm receiving therapy. HR mandated therapy. That's ridiculous. I didn't do anything wrong. Here's a list of things that you've done in the last 2 weeks alone. Force the anesthesiologist to scratch your nose because, and I quote, the patient's life depends on it. You can't.
Okay, so the idea of getting someone to scratch your nose in the operating room, it is a thing. I will say that traditionally, and probably where that came from in the past, was definitely surgeons' egos and surgeons kind of trying to demonstrate that they're sort of the boss in the operating room. The reality is, though, if you are distracted by an itch and you're sterile, it may be difficult to deal with that. And it's not unreasonable to ask for some help. And I've seen that happen before in the operating room. And when it's done out of a genuine kind of goodness of your heart situation, people don't mind. There are ways to scratch an itch, even though you're sterile. One example would be to take a sterile towel, put that in your hand, and then scratch. Again, that might be an option rather than having someone else scratch it for you. But you're sterile, so you can't touch yourself in any way. And you don't want to become contaminated, and that could have an impact on the patient's safety. So that's an important thing to consider.
operate with an itchy nose? You sent the circulating nurse on a wild goose chase in search of a 7 French fling-in looper, an instrument that by all accounts does not exist. Oh, come on, that was... And you attempted to demote a 4th-year med student back to 1st year because he didn't know the name of the keyboard player for Pink Floyd. That was a joke. You called the student's parents to inform them.
Okay, so this actually has a personal experience to me as well. When I was a medical student, even a resident, there were several surgeons that loved to quiz us on like random musical facts. And I think the purpose there is to create a conversation in the operating room, kind of break the ice, make the medical student feel a little more comfortable, because maybe there's going to be more difficult questions later. But some people will find even a simple question like that somewhat intimidating. I think joking about them failing a rotation because they didn't know the keyboardist for Pink Floyd. Have I heard that joke used before in the operating room? Yes. Maybe it's not the best one. This is not really made up. This is like... Obviously, Dr. Glaucomflecken's experience when he was rotating on general surgery was similar to mine. There are some surgeons who just love to ask you the ridiculous questions in the operating room.
Okay, maybe I took it too far. Surgery, you have an anger problem, and I want to start with some exposure therapy. Fine, but hurry up. I've never been in a non-OR this long. I'm going to show you a picture. Oh. Do you know who this person is? It's anesthesia. No, it's Mark. He has a name. They're always taking breaks. How am I supposed to learn their names? Oh, it's interesting.
Well, I hate to admit, I struggle with names in general, and I've more than my fair share of times forgotten the anesthesiologist's name. It's embarrassing, and I apologize to all anesthesiologists out there. I'm sorry. Sometimes I forget your name.
Interesting you have trouble remembering names, because just last week you were quoted as saying, "I have the largest brain in medicine." Yeah, everyone knows that. Okay. I think that's enough for today. Hey, I think we made some good progress. No, we didn't.
So surgeons definitely have a reputation for having a big ego. And obviously that's coming out here in Dr. Glaucomflecken's video. So I think we deserve it. I for sure, that's something that is, maybe something we could all work on. We could always develop our humility a little bit more. Okay, so let's do Dr. Glaucomflecken's Know the Anatomy.
Okay, where is our med student? Hi, I'm right here. Okay, what artery is this right here? Which artery are you referring to? This.
So I think this is quite realistic. You're in the operating room and you're trying to engage the medical students, and they're feeling the pressure, the intimidation of that, and you're, again, trying to identify some area that they can improve. Again, I can relate to this. Even as a fellow, I rotated in rotations that I wasn't an expert in, and you'd get quizzed in the operating room and you feel like, oh, I don't know what I'm doing. I can relate to that feeling.
This artery right here. It's hard for me to see what you're pointing to. Okay, let me try to get you a little bit better exposure. All right, there. Which artery is that? I'm not sure. The superior mesenteric artery? No. That was a trick question. This is actually the hepatic vein. Please read up on the anatomy before every case, and next time, anticipate my deceit.
All right. So I thought that was pretty funny. I don't think we try to go out of our way to trick a medical student to give them a trick question. We do want to make them a little bit challenging. But yeah, to point out and say, what artery is this? And then, it'd actually be a vein. Although interestingly, it'd be pretty hard to confuse the hepatic vein with the superior mesenteric artery. I think even most medical students wouldn't actually make that mistake, but it's possible. It's possible. I think Glaucomflecken's example here is a good one of just how difficult it can be. Like, what are you pointing at? What is it down there? And I can remember I was taking an exam. I was a second year, I think, or third year general surgery resident. And we were talking about the blood vessel that would bleed in the case of a perforated or penetrating duodenal ulcer, and I was referring to the splenic vein for some reason, splenic artery, or for some reason, which is totally wrong. And my staff consultant was like, "What? Like, you clearly don't know what you're talking about there." And so, even at times in our training, we're going to make big mistakes. We're going to say stupid and incorrect correct things. So I would say we definitely don't need to trick a medical student. The environment is tough and difficult on its own. That was my video. Thank you for watching. My name is Dr. Richard Hillsden. This is Knife Skills. I appreciate every single like and subscribe. If you want any more videos like this, please comment down below and I'll happily make some more. Have a great day.